Welcome everyone. This is the first in our mini-talk series on veterinary physiology. Today, we're focusing on the cardiovascular system, how the heart pumps, how blood flows, and why it matters clinically for every patient you'll see. Before we get into the mechanics, let's anchor ourselves. Why does cardiovascular physiology matter? Because this system underlies everything. When the cardiovascular system fails, every organ suffers. Kidneys, brain, gut, liver. That's shock, and it kills patients fast. Heart disease is extremely common. In dogs, mitral valve disease is the most common cardiac conditions. In cats, hypertrophic cardiomyopathy. In horses, atrial fibrillation. In cows, hardware disease can compromise the pericardium. Every clinical sign you observe, a grade 4 out of 6 murmur, pitting edema in the limbs, a weak thready pulse, or cyanotic mucous membranes is a window into the physiology. If you understand the physiology, you understand the sign, the cause, and the treatment. The heart as two pumps glued side by side, working in series. The right side is a low pressure pump. It picks up oxygen poor blood from the body via the vena cava and pushes it gently through the lungs. It doesn't need a lot of force because the pulmonary vasculature is low resistance. The left side is a high pressure pump. It receives oxygen rich blood from the lungs and has to push it all the way out to the body through much higher resistance vessels. That's why the left ventricular wall is so much thicker. The atria are essentially primer chambers. They top off the ventricles, particularly important at higher heart rates when filling time is short. The ventricles are the main workhorses. Key point, because the two circuits are in series, whatever volume the right heart pumps out, the left heart must pump out too over time. If one side fails, the other side is affected. What happens in a single heartbeat, the cardiac cycle. During systole, the ventricles contract. Pressure inside shoots up, snapping the AV valves, the mitral and tricuspid, shut. That's your first sound, S1, the lub. Then pressure exceeds that in the aorta and pulmonary artery. The semilunar valves open and blood is ejected. When the ventricles relax, pressure drops. The semilunar valve snaps shut. That's S2, the dub. During diastole, the ventricles relax. Pressure falls below atrial pressure, the AV valves open, and blood flows in. About 70 to 80% of ventricular filling happens passively. The atrial kick at the end of diastole contributes the rest. This is why atrial fibrillation, which eliminates the coordinated atrial kick, can reduce cardiac output, especially in patients with already stiff ventricles. Ejection fraction tells you what percentage of the blood in the ventricle actually gets pumped out. A normal dog has an ejection fraction around 60 to 70%. A failing heart might be 30 to 40%. But here's the catch. Some diseases, like hypertrophic cardiomyopathy in cats, cause diastolic dysfunction. The heart is stiff and can't fill properly. But EF looks normal. So EF alone doesn't tell the whole story. Cardiac output, CO, is the volume of blood the heart pumps per minute. The equation is beautifully simple. CO equals heart rate times stroke volume. Heart rate is how many times the heart beats per minute. Stroke volume is how much blood gets ejected with each beat. Multiply them together and you have your minute-to-minute output. Now, stroke volume has three determinants, and this is where clinical relevance really kicks in. Preload is essentially how full the ventricle is before it contracts. More stretch equals more forceful contraction, up to a point. This is the Frank-Starling principle. When you give a fluid bolus to a hypovolemic patient, you're increasing preload. Afterload is the resistance the ventricle is pushing against. High systemic vascular resistance means the left ventricle has to work harder. Vasodilators reduce afterload and can improve output in heart failure. Contractility is the intrinsic squeezing strength of the cardiac muscle. Drugs like dobutamine increase contractility. Positive inotropes, disease and drugs like beta blockers can reduce it. When CO drops, the body compensates: tachycardia, vasoconstriction, sodium retention. But these compensations have costs, and eventually they become part of the disease. The Frank-Starling principle is one of the most elegant concepts in cardiovascular physiology, and it's directly relevant every time you decide whether to give fluids. Cardiac muscle works differently from skeletal muscle in one critical way. Within a physiologic range, the more you stretch it, the harder it contracts. This is because stretching the sarcomeres increases the overlap between actin and myosin filaments, optimizing force generation. On the graph, the x-axis is preload. Think of it as end diastolic volume. The y-axis is stroke volume or cardiac output. A normal heart sits on the steep part of the curve. You give fluid, you increase filling, you increase output. This is why fluid resuscitation works. But there's a limit. Overfill the ventricle and you move on to the flat part of the curve. You're just stretching a muscle that can't respond anymore. Push further and you can actually decrease output. More importantly, you're raising left atrial pressure, which backs up into the pulmonary veins, causing pulmonary edema. The patient literally drowns in fluid. A failing heart, like a dog in congestive heart failure, operates on a depressed curve. Even with a lot of preload, it can't generate adequate output. This is why positive inotropes like pimabendin are so important in treating chronic heart failure in dogs. Blood pressure is determined by two things: how much the heart is pumping out and how much resistance it faces. Ohm's law applied to circulation. Blood pressure equals cardiac output times systemic vascular resistance. The arteries are your high-pressure conduit highways. The arterioles, the small vessels before the capillaries, are the key resistance vessels. They have thick, smooth muscle walls and can dilate or constrict dramatically, making them the main regulator of both blood pressure and blood distribution to individual organs. Capillaries are where the actual business of the cardiovascular system happens. They're one cell thick, and across that single cell layer, oxygen, nutrients, CO2, and waste products move by diffusion and filtration. Veins are massively underrated. They're capacitance vessels. They're thin-walled, compliant, and at any given moment, they hold about 70% of your total blood volume. When you give a vasopressor like phenylephrine, you're partly recruiting that venous reservoir to increase venous return and preload. Blood pressure is monitored moment to moment by baroreceptors in the aortic arch and carotid sinus. When blood pressure drops, they immediately signal the brain, which responds with sympathetic activation. Heart rate goes up, vessels constrict, BP comes back up. These reflexes happen within seconds. Longer-term regulation is the kidney, RAAS, pressure natriuresis, but that plays out over hours to days. Is under constant autonomic control, and this is fundamental to understanding both normal physiology and clinical arrhythmias. The sympathetic nervous system is your fight or flight arm. Epinephrine and norepinephrine bind to beta-1 receptors in the heart, increasing heart rate, chronotropy, increasing contractility, inotropy, and speeding conduction. Simultaneously, sympathetics constrict peripheral vessels to maintain blood pressure. This is what happens in a dog chasing a ball or in shock. The parasympathetic system through the vagal nerve does the opposite. It slows the heart by releasing acetylcholine at the SA node. Most healthy large animals, horses especially, are very vague at rest. A resting horse can have a heart rate of 28 to 35 beats per minute. That's normal vagal tone, not bradycardia. The SA node is the pacemaker. It fires spontaneously and sets the rhythm. The AV node is the gatekeeper. It intentionally slows conduction between atria and ventricles, giving the ventricles time to fill before they contract. Block that node, as in second-degree AV block, and you get dropped beats. When we see arrhythmias clinically, ventricular premature contractions, atrial fibrillation, sick sinus syndrome, we're seeing pathology in this electrical system. Understanding the anatomy of conduction helps you understand the arrhythmia or the ECG. Cardiovascular physiology is shared across species, but clinical expression varies enormously, and knowing these differences can save lives. In dogs, mitral valve disease is the most common cardiac condition. Cavalier King Charles Spaniels are particularly affected. Dilated cardiomyopathy, DCM, is common in larger breeds like Dobermans and Great Danes. The hallmark of DCM is a dilated, weakly contracting ventricle, systolic failure. In cats, hypertrophic cardiomyopathy is the big one. The heart wall becomes abnormally thickened, the chamber gets small, and diastolic filling is impaired. The sneaky thing about cats is they often look fine until they suddenly decompensate, sometimes presenting with aortic thromboembolism, or saddle thrombus, which causes acute hind limb paralysis. This is a cardiac emergency. Horses have enormous hearts. A big thoroughbred's heart can weigh 4 to 5 kilograms. Atrial fibrillation is common, but horses can tolerate it at rest because their large stroke volume compensates. It matters much more during exercise. Arrhythmias on auscultation in horses are common and must be differentiated from pathologic findings. In cattle, hardware disease, ingestion of a metal foreign body can cause traumatic reticulopericarditis. You'll see muffled heart sounds, jugular distension, ventral edema, brisket edema, and bottle jaw, classic right-sided heart failure signs.